This next one here is the tip is just to put the infusion in before you rip out a big IFB. This one, it was hard to say exactly how big it is, but it did make a good-sized wound that was in multiple dimensions. This is a large piece of glass. So if you rip this out and you don't have some infusion in the eye, you can get significant hypotony, and it can be very challenging to close. This patient had a good view back, so we could see that everything else was. Oh, sorry. This patient had a good view through the lens, so we could see the infusion. I wouldn't recommend putting in an infusion if you can't see it, but we were able to just slowly take this large piece of glass out of the eye.
Oof. Damn.
And this is, again, what I talked about. I do think sometimes it's good to take a quick look at the back. This patient had a macula on retinal detachment at the same time. Again, exact same technique to get the hyaloid up and over this tear peripherally. We did put in oil, and this patient is still attached. That's at post-op month 2, but we did take the oil out, and they're doing well. Although they did, to the earlier point about gas versus oil, and this patient did end up, I think, 2100 or 2150, and that may be the oil. So there are cases, especially if the oil is emulsifying, that it can affect the macula, because it didn't appear that macula was off, and it could be that there was some damage, but it looked pretty good in the surgery, so I'm surprised that he ended up and didn't end up with good vision.
Yeah, I mean, something to keep in mind in trauma is you get blood. That's a risk factor for emulsification. So, anytime you have a lot of blood in the eye, which trauma you definitely do, you're more likely to get emulsification faster.
And his photoshop is pretty good there.
Yeah. So Eric and Steve are both going.
Yeah, I mean, the thing is these have such high risk of PVR and everything else. I don't know. I still like to defer and use oil in many of these cases. I guess you just have to deal with that aspect. But there's so many other factors. I mean, it's a huge piece of. I mean, the fact that you're even maintaining that vision and that huge piece of glass is pretty incredible. But I don't think. I think if you put in gas with that, I'm just super skeptical that you would have potentially, blood, IOFB, that PVR risk was extremely high. And I think that, oil is still, that's still my go-to for those type of cases.
Oil is still the default. I would agree with Steve. I just was saying that I didn't really see the detachment super well in the video, but if it was a small single superior, that glass IOFB was sort of supranasal. So maybe it might've been a small, tear, small detachment, maybe gas, but yeah, you're never going to be faulted for using oil in a trauma case.
Yeah, interestingly, he developed a symblepharon to that wound with the iris that was pretty significant. So I think when we took the oil out, we put an AMT on it and cut it out, and then he reproliferated, so he got mucous membrane graft. But I hadn't seen that before, that a wound that bad got a symblepharon. He did it okay in the end, but it was pretty nasty.
Are some of these cases from Miami? I mean, this is like an amazing number of IOFBs. Have you had this many already at Mount Sinai?
I think these are